Good evening. Dr. Yasser. Okay. Good evening, everybody. On behalf of Iraqi Ophthalmological Society, we would like to thank the President of the NIOM, Dr. Mohammed Al-Amri, for his kind invitation for us to participate in this session, in this prestigious meeting. Now I want to invite Dr. Hamza Al-Majidi, the President of Iraqi Ophthalmological Society, for a brief appreciation talk. Welcome, Dr.
Congress, especially for Dr. Mohammed Al-Amri for his honors. Thank you all our speakers from Iraq who are attending this Congress, and hope to see you in our beloved city, Baghdad, in the near future. Thank you very much. Thank you.
Thank you so much. Our session will be a case-based discussion tackling DME in different situations. We hope that you get benefit from our experience and practice when dealing with diabetic maculopathy. To start with, I will invite Dr. Mohammed Tawfiq to present a brief introduction about management of DME. Okay, welcome, Dr. Mohammed.
So, good evening, ladies and gentlemen. We would like to give our special thanks for the organization committee to be here today on behalf of the Iraqi Ophthalmology Society. I will talk rapidly about DME in a nutshell. I don't have any financial disclosure. The pathogenesis of macular edema. We have to know that the main pathogenesis of macular edema, it's the capillary dropout in the deep capillary plexus that lead to reduce the venous and the fluid drainage. And after that, ischemia and release of VEGF and cytokine leading to the leakage, followed by fluid overload, molar cell overwhelm, and molar cell swelling and death due to glutamate toxicity. After that, we will have external membrane dysfunctions, and this lead to a supraretinal fluid and reduced drainage through the superficial capillary plexus. So the main pathology started in the deep capillary plexus. To understand the pathology, we have to know that we have two important factors. The VEGF factor, which is responsible for the starting of edema. And after that, there is the inflammatory cytokines, which is responsible for the further on leakage. The types of diabetic macular edema, we have the tractional and non-tractional, in which the non-tractional subdivided into non-central involved and central involved. Morphological classifications, we have to know that we call the sponge diffuse subretinal thickening, which is present in about almost cases of diabetic macular edema. This fluid leakage in the outermost retinal layers, usually if you see these pictures, associated with a good prognosis. The other type is the cystoid macular edema, which is present in about 50% of all diabetic macular edema cases. This is usually associated with a worse visual acuity. And the other type, it's a serous retinal detachment in about 10% of diabetic macular edema. And we have the tractional type, it's about 16% of all diabetic macular edema. In these cases, there is no rule for injection. These cases are managed by vitrectomy. And this is the ENFAS of the ENFAS OCT of the tractional diabetic macular edema. And the combined type, in which we can see so many different types. Workup. For workup of diabetic macular edema, we have to know, we use it for diagnosis and for treatment and prognosis. For diagnosis, we have the ultra-wide field fluorescein angiography, and we have to do the ultra-wide field in order not to miss any abnormalities in the far periphery of the retina. And of course, we have the OCT and the OCT angiography. Next. Which is very important in delineations, the fluids and the subretinal fluids, and also assess the enlargement of the phase and the foveal avascular zone. For the treatment and the prognosis, we have it's out, presentation. We have the diabetic macular edema biomarkers. In order to understand what is the diabetic macular edema biomarkers, next please. It's the usage of diabetic macular edema biomarkers, it's for the treatment selections. That's, as we said and discussed, the morphological subtypes and the hyperreflective dots. And even for a functional, the outer retinal bands, the drill, and the parafoveal vascular density. Next. Next. So for treatment selections, as we say, the morphological subtypes, we have as we said, it's a sponge managed by laser or anti-VEGF, other two types managed by anti-VEGF, and tractional by parsival vitrectomy. The hyperreflective dot, it is very important when you see an OCT. Next. Sorry, it's not... the hyperreflective dot, when you see these dots, it's a well-circumscribed spots. It's like the intensity or like the higher reflectivity than the RPE. This represents a lipid exudations and activated aggregated microglia. When you see these dots in your OCT, that means it's a chronic pathology and it's inflammatory markers, okay? So in these cases, it can be managed well by a steroid. The outer retinal bands, the external limiting membrane, the ellipsoid zone, the RB interdigitation, this is very important in order to assess the prognosis of the vision of these patients. For one of them is the drill, which we call disorganizations of the retinal inner layer. What's meaning of a drill? If I can able to segment the inner retinal layers by this one, these patients have no drill. That means this patient will end with a good prognosis. However, in the cases that you cannot able to segment the inner retinal layers, so these patients will have a poor visual outcome. Also, like in this case, these patients, despite the recovery of the foveal thickness, but these patients have poor visual acuity. Why? لأنه عنده drill, have a drill associated with a poor visual acuity. Other biomarkers, it's the parafoveal vascular density, in which we can take it from the OCT angiography, and it's very important when you see decrease in the parafoveal vascular density, these patients associated with the poor visions. Next. Next. How to start treatment? We have to understand, we have to take two parameters, the visual acuity and the OCT. For the OCT, we have to look at the center macular thickness, okay? Then we have two protocols guide us in the management, which is protocol V and protocol T, which is from the drcr.net, in which in protocol V, they say if you have a patient with a good initial visual, initial presentation was 6/9 or better, they say that whatever you do, like anti-VEGF, laser, or observations, have the same result after follow-up of the patient. This is protocol V. So they compare that, the result of these three items. Next. In protocol T, they assess the results of comparing the anti-VEGFs, the aflibercept, the Lucentis, and the Avastin in the cases of the vision was worse presentation, like 20/50 or worse. And they find that aflibercept has a good result to start with. So how to start? Usually take the visual acuity and OCT, give 3 injections, and then check the response. For the response, early response to anti-VEGF. When you inject your patients, the first 3 months, the first 3 injections, high responsible for the first year outcome or first 2-year outcome of the injection. يعني انت patients, you give him injection for 3 months. If these patients improve visual acuity, that means the patient will have improvement all the 2 years, okay? So it's very important to measure the early response to anti-VEGF. If we have good response, continue to anti-VEGF, stop if you have 6/6 or normal OCT, and then resume if you have a worse. How this slide is to summarize. You have to measure the baseline visual acuity and OCT. If you have a patient with 6/9, just observe. This is a protocol V. If your patient is 6/12 or better, any anti-VEGF you can use according to protocol T. Give 3 injections and then check the response. If your patients have 6/15 or worse, according to protocol T, you have to start with aflibercept in order to have a good result. Switching rules, how to switch. The switching rules on DRCR, we don't have a typical protocols or evidence base to switch or what to switch. But they say if you have a persistent OCT thickening, يعني not improving less than 10%, the vision of the patient is 20/40 or worse, and the patient does not gain 1 line of vision from baseline, this is criteria for switching of anti-VEGF. What to switch? We said we don't have any protocol. You have Avastin or Lucentis, shift to aflibercept. You have start by aflibercept, go to dexamethasone, and also you have 2 weapons, the laser and parsman vitrectomy. You can use them at any time. Thank you very much.
Thank you so much, Dr. Mohammed. Upon the presentation of Dr. Mohammed Tawfiq, we will start a case-based discussion. We will proceed with our cases. Next, please. First case, 42 years old
No,
female.
start from the beginning.
42 years old female presenting during routine checkup. Her visual acuity, the uncorrected 1.7, PES corrected 1. Regarding the OD, OS uncorrected visual acuity 0.5, PES corrected visual acuity 1. The OCT for the lady. Switch, please. Yeah. We will start with Dr. Hassan Bahrani. Upon the presentation, the lady during checkup, routine checkup, we find her good visual potential, best corrected visual acuity 1, but this is the OCT finding. What is your interpretation?
So this is a, hello?
Yeah.
Yeah, can you hear me? Okay. So this is a central involving, foveal involving macular edema, which what appears to be a central clinically significant macular edema based on the ATDRS with some macular exudate within 500 micron of the fovea. And it looks like the patient has focal macular edema. And in this case, what I usually do for my patients is first start with anti-VEGF. The reason I start with anti-VEGF is to allow the patient to gain visual acuity gain, and then I follow up with the anti-VEGF injection with a focal laser. And the focal laser is to treat all the microaneurysms. So there are two things why I use anti-VEGF. First of all is a quick visual acuity gain for those patients that they can notice within 10 days of treatment. The second thing is when I do the focal laser treatment, I've noticed that the laser uptake is much better after anti-VEGF. So if you have macular edema and you go straight to focal, then the uptake of the power of the laser is not much. So I usually go ahead and do anti-VEGF first,
What
and then
about the left eye?
So.
Does the option change for you?
Well, what's the visual acuity for this case?
The best corrected one.
Is what?
Yeah.
What is it? 1.
Yeah.
So I would take this option and this opportunity to advise the patient to, of course, follow up with their own internal medicine physician. Probably I would put them on Nevanac treatment alone and follow up closely with OCT, and then since they already received treatment for the first eye, I'll check them about a month later. I'll check their A1C, check their blood pressure in the clinic, and then follow up.
So you are going for follow-up
For
this
this,
patient with good visual potential, maybe would depend on protocol V.
Yes.
Okay. So what's your opinion, Dr. Yasser? Do you have other option?
Yes. Assalamu alaikum. Nice to meet you all. Regarding this case, I see that the visual acuity is very good. It's the best corrected visual acuity 6.6 in both eyes, with focal maculopathy in both eyes. So of course for this case, first we have to send the patient for his physician to control his diabetic status, and inform the patient also to control his lipid profile, renal function, everything regarding his systemic condition should be controlled. And of course, we will discuss with the patient because he has very good visual acuity in this eye. Of course, if we want to interfere in this case, because this is like Dr. Hassan said, it's according to EDTRS, this is a clinical significant macular edema. So the patient may later on complain from center involving macular edema. So I give the patient the option that this case can be treated by focal laser treatment. I don't usually advise to give, for example, in this case, anti-VEGF injection because of the very good visual acuity. So either I do, for example, focal laser treatment with modified grid laser or with a micropulse laser treatment. Because I have previously experience with micropulse, it was very nice in these cases.
Thank you, Dr. Yasser. And really, this is the story of the lady. What I do for her is a micropulse laser. And this is the result post-laser after. And if you remember, this is the OD. And this is the OS of the patient before laser. And this is after laser. This is the OD, and this is the OS. Really, I have written here focal is not a focal. If you notice, there is no burn at all. It is a micropulse laser for the is OCT guided laser for the outer ring. And this is the result after laser photocoagulation. Okay. The next case. 50 years old diabetic male presented with a gradual visual impairment, the uncorrected visual acuity 0.15, best corrected 0.3. This is the OS. And Dr. Mohammed Tawfiq, can you interpret this OCT finding?
This is the OCT pictures of the left eye of this patient, assuming that have all types of edema that we know, sponge, cystoid, subretinal, and also in some, but the good things that she have a good external membrane, the ISOS junctions and drill, it's a good, okay? So in this case, it's a typical diabetic macular edema. for this case, I will start directly with aflibercept. Why aflibercept? According to protocol T, because the initial presentation of the patients is about 0.1, so I will go to aflibercept, ask the patients for 3 injections, then after that we will check the response and we will decide whatever to continue. So for this case, I will go for anti-VEGF direct.
Can I ask you when you start your first OCT post-injection? After how long?
4 weeks.
After the first injection, you assess the response?
Every 4 weeks. I don't do the OCT early after injections. When you inject the patients, after 3 to 4 weeks, I will do the next OCT.
Is it enough to assess the response? And you said my patient is
Look,
respond
Dr.
or not?
Suzanne, in the first 3 months, okay, you will not check the response after the first month or second month. You will check the response after the third month.
This is my
Yes.
question. Yeah. Okay.
But we have to do it monthly OCT.
Monthly you do? Okay.
In order to, as a baseline comparison, and it's also some psychological support for the patients when he see the edema is improving and decreasing in the central thickness, foveal thickness. So the response, to check response, that's the aflibercept is working or no, this is after 3 to 5 injections, okay? But what OCT I do every month OCT before the injections.
Okay. And as you said, the science of response in OCT to judge whether the patient respond or not, or you switch or not, you depend on what parameter?
First of all, we check the visual acuity improvement of the patients, how many lines he gets from the initial presentations, the subfoveal thickness. If I reaching more than 10% of the initial presentations, so that the patient is improving. Okay, so if I start by 600 and the patient of that come to 400 microns, that means he's improving. So in this stage, even if I don't reach to dry macula, I will continue on aflibercept. I will not switch. Okay, so this what I said that the good response signs. If you have a good visual acuity, you have a stable VA, and you have stable. Sometimes you have a stable visual acuity and a stable OCT thickness, despite this not improving too much. Okay, so this is also described as a good response.
Dr. Hassan, please, when you start to switch or to decide whether to switch or not, you depend on a 3 month or you complete the loading dose after 5, for example, with aflibercept?
Yeah, I would say a 3-month check. So it's usually 4 months after initial treatment, because of the 1 month post the last third injection. And I think a lot of sometimes I think patients push us to change because when they don't see significant improvement in results, you kind of have to go along and show the patient that even sometimes we switch, they're not going to benefit from switching. And we have to reassess the situation. But mainly for these cases, I had a lot of patients resolve their macular edema resolve, but just by improving their systemic profile. So in my clinic, I usually have the ability to check for A1C and blood pressure, because a lot of patients, even their A1C is controlled, sometimes their blood pressure is very high and they continue to leak, and they don't respond a lot. So if they don't have a response to injections, then I think about systemic issues. And in this situation, and when they don't improve, if for example, I'm on Lucentis, then I switch to Eylea. And if they're not improving to Eylea, then I'll probably go to Ozurdex. And also we have to think about the social issues, logistical issues with my patients coming from a distance. So Ozurdex gives me sometimes the ability to have the patient follow up every 4 months instead of every month.
Okay, Dr. Yasser, have you switched after 3 injection or you wait for late responder?
Yes, I depend first of what anti-VEGF I start with. For example, if I start with Lucentis, of course I will reassess the patient after 3 months regarding the visual acuity, the OCT, and everything, signs of inflammation, everything I will check. And if the patient have no response at all, for example, there is, according to protocol T, there is no response when there is no decrease in the central retinal thickness by more than 10%, or there is no improvement in the visual acuity even by 1 line. So of course, at this step, I know that I have to switch to another anti-VEGF. For example, if I start with Eylea injection or aflibercept, I need to continue till 5 injection. And after 5 injection, I reassess the patient. And if I see, for example, there is a 10% improvement in the central retinal thickness and improvement in the visual acuity, of course, I will have to continue. But if there is no improvement in the central retinal thickness and the visual acuity not improved even by 1 line, of course, I have to think to switch to another anti-VEGF. And of course, I have to ask whether the patient is phakic or aphakic. So, phakic or pseudophakic, because this will interfere to which other agent I will
Okay,
switch.
okay.
Thank you.
And this is the OCT after 6 months, the final result. What is next? Okay, Dr.
Okay.
Yasser.
So-
Same patient
Yes.
after 6 injections.
Yes. So after 6 injection, I saw that the central retinal thickness is improved very well.
Okay.
So I want to know the visual acuity also. If the visual acuity and the central retinal thickness, both of them is good, of course I will put the patient on the PRN. I will follow up the patient every 1 month. And I will check the OCT and the visual acuity every 1 month. And of course I will advise my patient for strict diabetic control and everything. And I will follow every 1 month to check. If he is stable, I will continue follow-up. And if there is any recurrence or any, for example, re-edema or the visual acuity decreased by 1 line or the edema is increasing, so of course I will re-inject with the same treatment, which was, of course, in this patient after 6 injection, he is improving. So I will continue on the same treatment which he is using.
But still there is edema. How you treat?
I would do.
You would add something?
I would treat and extend. I would do treat and extend. So I'll go from 4 weeks every to 5 weeks or 6 weeks, and then reassess and then check again, and then I'll probably go to every 2 months. But these patients, I counsel them initially on their initial visit that this is a chronic issue, and this chronic issues need to be treated chronically. So I wouldn't, take them off the line. So I would just keep them under follow-up and injections.
Okay. Our third case, 50 years old, diabetic patient after 6 injection of anti-VEGF, still best-corrected visual acuity less than 612 with unresolving cyst. Dr. Mohammed Tawfiq, have you faced such a resolving cyst after treatment?
So one sign of chronicity, when we see the cyst, is a sign of a chronic disease, as Dr. Hassan said. And we say that it's responsible for a poor visual acuity of the patients, even this patient is improved. So which anti-VEGF the patient is used, which anti-VEGF he take?
The patient treated with aflibercept.
He take 6 injections?
No, 5.
5 injections.
Any, for example, anti-glaucoma medication, if the patient have eventful cataract surgery, or if the patient have any risk factors for Irving-Gass syndrome, of course, we have to exclude this first. The second point, of course, with the OCT, we can't judge something from the OCT. So, for example, as Dr. Mohammed, I totally agree with him. So, for example, with the OCT, if we see subretinal fluid, serous detachment fluid, subretinal fluid, and there is loss of the foveal reflex, blunt reflex, of course, and for example, the visual acuity we have to check. So this is mostly Irving-Gass, of course, with the fluorescein angiography. But in this case, I suspect that this is a progression of diabetic macular edema. So there are certain criteria to differentiate between these two.
Just one point, as far as using, it has been shown, and actually I have done research on that Nevanac works better in Irving-Gass syndrome than Acular.
Okay.
Nevanac.
And this is the eighth case, 16 years old girl with insulin-dependent diabetes, presented with visual impairment and corrected visual acuity 0.3. And this OCT finding, as it show, combined BDR with maculopathy. So, Dr. Hassan, your interpretation regarding this case?
So this patient, this is a cross-section OCT of the left eye with a fundus view showing possible NVD, right? Front NVD here.
Obvious.
And we have diffuse macular edema with the inflammatory biomarkers. And this is pretty severe active PDR along with the DME. So in this case, you have to be aggressive, especially with the patient being type 1 diabetic. So I would initially start both with anti-VEGF and PRP treatment on the same day, and just continue with anti-VEGF treatment and supplement it with PRP unless I have achieved a full PRP treatment. And she would probably need definitely workup by an internal medicine physician to make sure that she's well controlled, which is probably not controlled, because that would affect tremendously the success of the treatment given.
So, يعني دكتور حسن, أنت you start injections and PRP at the same day?
Yes.
At the same day?
Yes.
You
I would do
first PRP,
Yes. And
then injections. Because I will do, of course, these patients need urgent PRP and injections. But for me, in this case, I will start first with a PRP, even not complete PRP. Whatever I can see, I put PRP. Then I will inject, and then after 2 weeks, I will resume for the full
Why
PRP.
not start injection, then inject, then PRP?
Because this is a bomb. It will explode any times, and you cannot control that. Have a florid, aggressive NVD.
Aggressive NVD,
Yes, florid and aggressive NVD. And so in this patient, the NVD cover more than 3/4 of the disc. So this patient's the severe PDR. So it's may have developed vitreous hemorrhage anytime, and now it's difficult for me to do PRP. So I will first of all start with a PRP, even in the periphery, just to settle down. The next day I will go for injections, and after 2 weeks I will complete the PRP. Dr. Yasser, شنو؟
For me, I will start with anti-VEGF in this case.
Me too.
Because I think that the anti-VEGF will work on both of them, on the proliferative diabetic retinopathy and on the macular edema. And after that, for example, just when I see that the proliferative and the diabetic macular edema, I, of course, will do PRP. So this is case for combination treatment, of course, anti-VEGF and PRP. Of course, if we can start immediately, for me, I will start with anti-VEGF and then PRP.
Yeah. This is the right eye of the same patient, Dr.
What's the
Hassan.
point? What's the point of waiting for the PRP? I mean, you want to get PRP there as soon as possible. I mean,
Yes,
even
as soon
even
as
if
possible.
even if she bleeds, and then you end up doing vitrectomy, then you probably have PRP, and that would actually help you during vitrectomy.
I think in the previous case, the urgency for the PRP is more than the urgency for management of diabetic macular edema.
But anti-VEGF work on both.
This is protocol S. I was
with rapid regression
yes,
of a new vessel.
But still PRP is the
Within
mainstay,
2 days.
because now we have the anti-VEGF will decrease the vascular density, will decrease the edema. This is according to protocol S. And by the way, I was one of the big fan of protocol S, and even I start to use it in some patients, especially the high education. I start to give him injections despite have PDR. But unfortunately, we go back that PRP is the mainstay treatment for PDR. In the previous case, the patients have 2 risk factors, have aggressive new vascularizations and have edema. So I think it's the urgency go for the PRP, and of course we will continue on anti-VEGF. For that reason, I don't delay the start of PRP.
So whatever the starting agent here, the patient require urgent management, whether you start with PRP first or whether you start with anti-VEGF, but with rapid, with short period of time between anti-VEGF and PRP, we should take the condition serious. The story differ with the left eye with the right eye of the same patient. Dr. Hassan, do you see this case as medical or surgical retina?
So obviously, this is a cross section of the right eye OCT and fundus photography. Definitely, looking at the fundus photography shows obvious superior stria with macular traction at the edge of the superior arcade. Here we see a very taut epiretinal membrane with diffuse macular edema, and this is obviously a surgical case. So, I mean, you can go about doing this in different ways, but I would probably consider anti-VEGF treatment followed by vitrectomy, or anti-VEGF plus PRP. Then I would perform vitrectomy for this patient. The point about this surgery is that you want to operate when the patient is quiet, is not active. So giving anti-VEGF is very important. Supplementing with PRP is just I would say, an extra bonus. There's a lot of studies shown that patients who have already had PRP do better intraoperatively and postoperatively with less complications intraoperatively. So in this case, anti-VEGF, PRP, and then vitrectomy.
You don't aware about the using of anti-VEGF and worsening of tractional element here, or what's your...
Sorry? Excuse me?
You don't aware about the progression of the condition with the anti-VEGF here, tractional element?
Yeah, I mean, you probably would operate within probably a week to 2 weeks, not more.
Okay, so it's better to be treated by surgical retina. Yani he will prescribe the anti-VEGF and he will do the surgery.
Yes, obviously.
Okay.
That's a very good point. His referral is a very good point in this.
Because worsening of the condition after that.
For the audience, have to get this message that these cases should not be managed by even medical retina or a general ophthalmologist.
this is
Never inject cases of retinal membrane, because this will end by a tractional detachment or even a development of a macular hole. So these cases is better to be managed by a surgical retina.
And then the contraction syndrome, where you've seen a total retinal detachment.
Not any epiretinal membrane.
And
Not
you
any
develop-
epiretinal membrane shouldn't be treated by medical retina.
Well, no, there's a lot of epiretinal membrane
yeah, but
can be
in this
treated.
case,
This is
in this
different.
case, with the tractional element,
Yeah, they can get
is a good
contraction
message.
syndrome, where I've seen a lot of them, just the retina pops
Okay.
up, and then you develop a rhegmatogenous detachment for a simple one
Okay.
anti-VEGF.
Yes, it's a good message. Okay, good.
So, of course, I totally agree with Dr. Hassan that this is a case of tractional membrane with a tractional retinoschisis and diabetic macular edema. So this is better to be managed, as you said, by a surgical retina specialist, because this case need to be, for example, done anti-VEGF, PRP, and stabilize the condition, and then do the vitrectomy, because there is tractional retinoschisis in this case.
Dr. Mohammed, how we can differentiate whether in the presence of epiretinal membrane, whether this edema due to diabetic maculopathy or is it a tractional edema, for example, by the OCT finding? Is there any specific pattern?
The ONFAS technique, the ONFAS of the OCT, it's shown that the presence of this diabetic the epiretinal membrane, due to the inflammatory markers or the chronicity, it will appear the chronicity and appear the severity of the epiretinal membrane traction on the macula. So the ONFAS is very important.
And the special orientation of the cyst, the elongated cyst may go more with the tractional element rather than diffuse diabetic exudative maculopathy. If it is a longitudinal oriented cyst, it's mostly go with the tractional diabetic maculopathy rather than exudative one.
I think having your own patients for a long period of time, you would kind of know also that this is more epiretinal membrane. I have so many patients, just a stable epiretinal membrane. Looking at the OCT images, it shows macular edema, but it's just because of the just how the OCT reads it as macular edema, but it's reading the epiretinal membrane.
Okay. And the last case. No, this is the ninth one. Diabetic patient with significant visual impairment and corrected visual acuity 0.15, and this is the NFAS OCT for the patient. And Dr. Yasser, would you explain to us the cause of permanent drop of vision and how you proceed in treatment, whether you inject or not?
Okay, so this case, as it's obvious, there is a taut posterior hyaloid face with epiretinal membrane and with a lamellar hole. So this case, of course, there is a lamellar hole, there is a taut posterior hyaloid membrane. So of course, one of the causes of the drop of the vision is the lamellar hole. But the strange thing that this is significant visual impairment. So of course, I need to do, for example, OCTA or fluorescein angiography in this case, to be sure that if there is any macular ischemia or if there is any leakage in addition to the tractional component of the epiretinal membrane with the lamellar hole. Because significant visual impairment in this case is because there is, as I see that the ellipsoid zone is intact and the vision is significantly impaired. So I have to exclude first whether this is a macular ischemia, whether this is associated with diabetic macular edema. And then this is also if it's significant and there is no macular ischemia, no leakage, of course we will go for parsoplantar vitrectomy to close this hole and to see what is, we will explain to the patient what is the prognosis in these cases. We need to close only the hole and see how much is the vision will be improved in these cases.
So I totally agree that this case is a surgical retina should be treated by surgical retina senior, and the cause of poor visual acuity here is the presence of lamellar hole and other prognostic factor regard the ellipsoid zone intact, regard the external retina membrane looking intact. So the cause of poor visual acuity here is the lamellar hole. Do you have any comment about this case, Dr. Hassan?
Yeah, I accept recent evidence have shown that ILM flap technique in these cases do improve visual acuity a lot in patient with the lamellar macular hole. So it's just not peeling, it's actually performing the ILM peeling with ILM flap to allow better visual functioning post-op. So ILM flap in this case actually they do very well.
They have better prognosis?
Yes, visual acuity prognosis is better than just peeling.
Oh,
so
just
peeling, but also doing ILM flap.
Okay, yeah, inverted flap. The 10th case, a pregnant lady with insulin-dependent diabetes with base-corrected visual acuity 0.3, and her OCT finding, OD and OS obviously showing cystic diabetic maculopathy. How we proceed in treatment of this special case, the presence of diabetic maculopathy in pregnancy?
Yes. So, of course, we need to know in which trimester this pregnant lady. She is a diabetic patient with significant center-involving macular edema. We need to know at which trimester that this pregnant lady is presented to us. For example, if she is presented in the 3rd trimester at the end of her pregnancy, sometimes we can wait until she gets delivered, and then we will, of course, we will proceed with the anti-VEGF treatment, which is contraindicated in pregnancy. But if this lady presented, for example, in the 1st trimester, of course, we need to interfere with this lady because there is a long period of time of waiting time, 6 months, 7 months. So, of course, the safest treatment, either laser treatment or Azordex or steroid treatment. This is the safest for me, either laser treatment or steroid. But with the steroid, most of them, they are young age, so we have to explain. If they accept to do this with the risk of the cataract and the intraocular pressure, we will go for steroid. But for laser treatment, modified grid is okay for this case.
Do you have any other option?
Yeah, I would, a lot of those cases come and they do well with a grid focal laser.
With a grid. So we want to highlight the role of laser. Laser still have a role in the presence of for diabetic maculopathy.
Yes.
We noticed the first case, we can do focal laser photocoagulation, whether you choose focal, whether you choose micropulse, whether you choose a grid. Laser still have a role in diabetic maculopathy. And but Dr. Mohammed Tawfiq, he doesn't agree. He's using almost anti-VEGF. Anti-VEGF. He's using anti-VEGF only. Yeah. Okay.
Yes,
so another rule of laser here, Dr. Hassan, you will treat the patient with laser, grid laser, modified grid.
Yes, and Ozurdex.
Or Azordex.
Absolutely,
Yeah.
absolutely. Ozurdex
is a good option.
Yeah, it's a good. No, I've just Ozurdex has been, a game-changing thing because it really saves you when anti-VEGF doesn't work, when you're in a certain special situation like this. I think it's a very important tool that we can use in addition to the anti-VEGF.
We have to understand that even sometimes, as we mentioned, that cataract induce sometimes progression of diabetic macular edema after surgery. We have to know that pregnancy also inducing a changes or rapid changes in the diabetic status of the
Yes,
patient.
yeah,
So,
okay.
and sometimes the patient this pregnant, if she put her baby delivered, after that she may be improving the
Maybe
edema.
regression
Yes.
of edema
Yes,
alone, without
regression
a
of the edema.
treatment.
So the most important things in my for me, I will control the HbA1c of for this lady during the pregnancy. Maybe I will prescribe for her topical non-steroidal. I will not go rapidly anti-VEGF. We cannot use it, and sometimes I will go either for monitoring of the patients with every month coming and control of the HbA1c. And if I see that she is well controlled and the edema start to worse, I will go for other drugs.
Dr. Yasser, I want to ask you about the role of non-steroid, topical non-steroid anti-inflammatory agent in phakic eye, okay, and diabetic maculopathy. Do you agree that it's have a rule?
There is a protocol that mentions it doesn't have a rule.
Okay, yeah, I
But
agree with you.
of course, we all use it because it's sometimes it's showing a result. But the protocol, I don't remember which protocol. It compare the non-steroidal. Maybe Dr. Mohammed know, but there is a protocol mentioned that it's not effective in treatment of diabetic macular edema, for example.
Okay.
I know that's some many protocols that are moderated by the company itself. يعني لما تطلع قطرة اسمها Acular تقول no this eye drops manage the diabetic macular edema very effectively or pseudophakic macular edema. تطلع قطرة ثانية شركة ثانية تقول لا النون ستيرويدال هذا مو قوي نستخدم النون ستيرويدال الثاني. So we don't have to follow the commercial studies or something like that because they always try to push you for themselves. But all of us, even medical retina or general ophthalmologist, we use the topical non-steroidal and we see it have a result. يعني دكتورة سوزان to use the
Even
topical
in the
non-steroidal.
presence of phakic eye.
The patient want result, does not want evidence-based. The patient
I
will not
used
go back
for
to study the evidence.
pseudo-phakic patient, really, it has a role.
It have a result. So the
It's
patient don't need
pseudo-phakic,
to explain for him the study, look this study, and he, at the end he want the OCT, the macula is flat and the vision is good. Despite you give him non-steroid, you give him shawarma, you give him anything, he want to be improved, okay? So for I think for my opinion, it's work. What do you think, Dr. Hassan?
Okay.
Sorry.
Do you have any further
No, no,
comments? Okay.
After this.
The next two videos with Dr. Hassan. Wait just a minute. I take the opportunity to invite you for our upcoming event, the 17th Iraqi Ophthalmological Society Conference at the 23rd and 24th of November in our nice city, Baghdad. I hope that we will see you there. And may I invite Dr. Hassan Bahrani to interpret his next two videos.
Hello. Yeah, actually, it's not much. It's just an example showing. Can you go back, sir? Hello? Sir? These two guys. Two slides. 2 slides back. Hello? Go back. Okay. Okay, one more. Hey. So play. Where's the play? The play? Play? So this is a case, these are very short cases. This patient has diabetic macular edema with play. So go back. So you see this patient has extensive taut posterior hyaloid. Notice here, it's sometimes it's just not peeling the hyaloid. In this case, there's the stalk of hyaloid stuck, where this case of vitromacular traction. And I had to kind of, I didn't want to pull on the vitromacular traction, obviously, to reduce the risk of macular hole, but here, going around the vitromacular traction epicenter, I was able to peel this this epiretinal membrane, and surely enough, this vitromacular traction was released and relieved from the retina without causing macular hole, because usually you just have to counsel the patients in these cases about the risk of macular hole when you're peeling membranes. What you notice also about these cases with vitromacular traction is that the ILM is very sticky, very tough, not easy to peel. So it's a different component. It's a different animal, different ILM. This is the other case I have, just showing, highlighting sometimes, highlighting that some diabetic macular edema has tractional component. If you don't take care of those tractions, anti-VEGF actually will make things worse. So in this case, we're peeling this tractional component from the disc and peeling it. So this just shows an example that sometimes when you're encountering patients who have tractional components, it's better to not continue with your treatment plan with continuing anti-VEGF, assess the situation, assess the OCT, get a color photo if you're having difficulty examining the patient, to make sure that you're not continuing with a plan that may hurt you at the end. Because what I find sometimes with patients that have tractional component and you keep injecting them, they usually have poor prognosis, and they may develop actually ischemia from injections, as well as complicates our surgeries and our vitreoretinal intervention. So that's, and it's sometimes not straightforward. Doing surgeries for those patients is not straightforward, as you saw in the first case where the vitromacular traction, I was expecting it to peel. Excuse me, hello? The IT team, can you go back to the video? The first video. I think they need, So here, I thought this case is done, and then I noticed this stalk over the disc, and I just stopped right there because it wasn't peeling. So that was the thing where I start going around it. So I was dissecting 360 around this tractional area because you can't just pull on it. And see, it just looked like a flower there. And then when I peeled again, I just had to kind of go and peel around it until it kind of released from the macula. So it's sometimes not straightforward cases. Thank you.
Thank you so much, and thank you for your attendance. And Dr. Hamza Al-Majidi have some word to conclude the session.
Thank you very much. Very nice, important, informative experience we heard today. Thanks, Dr. Suzanne, Dr. Hassan, Dr. Muhammad, and Dr. Yasser. Great thanks for the audience. All the best and success. Meet you again, inshallah. Thank you very much. Thank you. Thank you. See you in Baghdad next November, please. You're welcome.